this is our presentation for the putting it all together. And yeah, here we go. So let's share the screen. There we go, and share. Okay. So go ahead and lead it off there, Amada.
All righty. So we have, I'm just going to read off the case. A 24-year-old Gravida 1 Para 0 woman named Maria presents to the hospital. She is 34 weeks gestation and having intermittent pelvic pain, which she believes are contractions. Maria is accompanied by her 39-year-old boyfriend. Social history: Maria lives in a mobile park with her partner and his 7-year-old daughter. She states that she strongly considered giving up the baby for adoption because of financial and other reasons. She reports she has not had any prenatal care, but has been taking care of herself. She states she has quit smoking and drinking and is eating daily. She is not currently working as she recently lost her job, and states sometimes learning new things is really hard and things have been very stressful. So she relies on her partner for support. She states she is not close to her family as there is a history of significant physical and emotional abuse with her mom and stepdad. So I guess kind of going through those, picking out things that stood out. First, the patient hasn't had any prenatal care. So the assessment, we have to be thorough to ensure that the baby's okay and she's okay. In terms of weight and nutrition, since she says she is eating daily, we want to assess what that means. Was she not eating regularly before? So kind of barriers to nutrition. She has a history of smoking and drinking, so that could potentially be adding to her risks or in the baby's risk of complications. When did she stop smoking and drinking? From when she knew she was pregnant to then. And then she also states financial reasons for possible adoption. So the financial reason could be a reason as to why she's not receiving prenatal care. So we want to assess her, does she have insurance? Does she have proper, just I guess the financial stability to take care of herself and the baby, and the resources we can connect her with. So the social worker.
Yeah, that's one of the biggest things that I kind of found for her was linking her up with a social worker to really kind of get some of those resources that were kind of needed for her.
Yeah, I think that was a big thing for her. I think like the bottom ones, like what kind of interventions for psychosocial.
Yeah.
I think the social worker is a big thing for her and the family.
Yeah.
For financial, and also we'll see
Would they
later
help
with
with
depression.
would they help with the other reasons too?
They could.
Yeah,
kind of dig into what the other reasons why she might have something.
Right. Okay.
Yeah, and then so another part was the history of physical and emotional abuse. So I kind of want to make sure she's not still going through abuse at home.
Mm-hmm.
I made a point on the family-centered intervention deal that to really kind of eliminate, since she's not close with her immediate family, that her family is now just kind of her baby and her, and that kind of needs to be the family-centered intervention. So getting her involved in like some kind of like familial violence or domestic violence kind of treatment and stuff
like
like
a therapy group.
Yes, have a support system at all, it seems like.
Right. And then it's like, what is her relationship with the 7-year-old daughter? Is the 7-year-old daughter getting, possibly abused as well?
Right. Yeah.
Because we would want them to check out that as well, right?
Yeah, absolutely.
Okay.
There could be a lot more going on behind the scenes that we don't really know.
Right.
Kind of getting in and asking her some of those questions and getting that social worker involved for sure.
Yeah, like one of the risk factors for like abuse is that they financially rely on their partner, and that was kind of a big thing that
Mhm.
kind of
That's
mentioned
why-
it in the case. Yeah, she lost her job and she relies on him, so that
Mhm.
can be kind of a hint.
So I think that kind of covers a lot of the psychosocial stuff. So the other side of things would be her physical presentation would be
Mhm.
a lot. There's some pretty important stuff there. Like with her blood pressure, it's definitely very at risk for like preeclampsia. She's definitely in that zone of we need to start considering treatment, since she also stopped, or she had her high blood pressure medication for a few years. But when she found out she was pregnant, she stopped taking that. So we need to start getting some like pharmacological interventions on board to really get that blood pressure down.
That
Yeah.
and then her pelvic pain, at 34 weeks gestation.
Mhm.
Because the first thing that came to me is like, okay, is she getting her hydration every day? That's the first thing that I thought about.
Yeah.
You didn't mention that in there. And then the other thing with the UTIs, because of the hormones and how they interact with the body, is kind of common in pregnancy. I was reading about that.
Seems like her physical presentation also puts her at risk for preterm labor.
Yeah.
Right.
Very pale and notable bruising on her arms, back, and legs. The notable bruising on her arms, back, and legs, does that relate to the violence type of thing, or what's going on there? Like that's those are a lot of questions we do need to ask her as well. Maybe does she have any periumbilical bruising and stuff like that too? So that's kind of stuff we need to
Right, like signs of trauma
Right.
to
that
the
could
to the
indicate, yeah.
uterus. So what else?
We need to address her depression and the fact that she stopped taking her medications for her depression. That puts her at many risks. I think since she's obviously kind of at risk for preterm labor, this can be a good way to kind of assess for the violence, because she's going to be in the hospital probably long term, at least a couple days. So just making sure that an assessment can be done without him around to kind of dive into the bruising and basically the lack of care. She probably didn't come in because there is a history of violence. And that's probably why she didn't get the prenatal care and all of that done.
Yeah.
But the immediate, would be the blood pressure and her risk for preterm labor.
Yeah, get that blood pressure back down into like the 140s. Let's see, maybe even considering to implement if we're in the emergency room situation or whatever, implementing some seizure precautions just because her blood pressure is really high. So stuff like that.
And then she'll likely get treated for the infection depending on the culture.
Yep.
Yeah. Overall, I think her blood pressure is urgent. I think that's probably the
most
priority, along with the low amniotic fluid to make sure that the baby is okay. So we want to assess the baby. And then once she's stable, really dive into the psychosocial, the signs of abuse and lack of care. And then kind of with the social worker proceed to like assess like, where do we go from here? If she really does want to do the adoption, kind of providing information for that.
Well, cool. I think that that kind of wraps that up. Is there anything else anybody wants to add to this case study?
No, I don't have anything additional to add.
Okay, so this is the case study for the PEDS. Go ahead and share the screen here. And share. There we go.
Okay, so we have you're a nurse practicing in the school setting in a rural Title I community. It is the beginning of the school year, and one of your 7th grade students on your caseload is 13-year-old student named Aiden. Aiden is an only child in a single parent household. Aiden's grandmother was living with Aiden and his mom until she passed away in July. Aiden's mom is a local retail grocery assistant manager and works evenings and weekends. Aiden receives free and reduced meal lunch, or reduced meals, and eats both breakfast and lunch at school daily. His breakfast is at 7 a.m. and his lunch at noon. Aiden is an overall strong student and very social and has specific learning disability called dyscalculia. So the first things that kind of stand out for me is after school, his mom is not home. So kind of how is that affecting Aiden and his growth, and then also his disability if his grandma's not around anymore, who's taking care of him and meeting his care needs. And then, so they made kind of a big point on presenting the meals. So is there a barrier to nutrition at home with this, maybe the single parent financial barriers? Mom is gone a lot. So how does that play into effect with his learning disability?
The other point too, that Aiden, the grandmother, it sounded like she passed away recently. You know, so like, how is that kind of affecting the family dynamic right now, kind of thing? Let's see here. Is there anything else on the social history that
I guess kind of if they have any other type of social support close to them?
Yeah, so I read through this study that they have no family that live close to them, so that heavily affects his social community support networks. So he does suffer from some social detriments of health. The fact that he's being raised by a single mother, the fact that he qualifies for free and reduced meals means that her income is below federal poverty level. So that puts them at a lower socioeconomic status. And so all of those will affect his development for sure.
definitely? So I think we're good to move on to the medical history then. Cool. So Aiden is otherwise a healthy child who is fully vaccinated and diagnosed with both attention deficit hyperactivity, or ADHD, and type 1 diabetes in early elementary school. Aiden is able to provide a lot of self-care with his diabetes management, and you have delegated some of his daily care to an unlicensed assisted personnel. Aiden has an insulin pump and continuous glucose monitor. His pump has basal insulin levels set at home and receives mealtime boluses at school. Aiden's mealtime insulin cover ratio is 1 unit per 12 grams of carbs. His blood sugar correction dose is 0.5 units of insulin for every 50 milligrams per deciliter over 150 milligrams per deciliter. Aiden also takes his methylphenidate 30 milligrams PO at breakfast and 20 milligrams PO at lunch. A lot to unpack there on that one.
Yeah. So the fact that he has the dyscalculia, which means that he has an impairment in learning number-related concepts, he most likely will not be able to accurately calculate his carb intake for his insulin dosage requirements for his meals.
Right.
So the fact that he's often left home in the evenings, and it sounds like weekends as well alone, he's not going to be able to manage that for his meal times.
Yeah, absolutely.
I agree. And then with him having that ADHD on top of that, he's not gonna be able to focus long enough to learn how to do that, even if that's a possibility.
Yeah, and you couple that with his social history where his mom isn't like home regularly after school,
Right.
And the grandmother that recently passed away that may have been handling some of that as well. He's kind of left to his own devices to really kind of
Right.
care for his own diabetes. And at 13 years old, that I think is a lot to ask any 13-year-old kid to do. But yeah, I think that's definitely some stuff that both parental education is going to
Yeah, definitely. Definitely, because grandmother did take care of it before.
Yeah.
Mhm.
So
Yeah, it seems though with that disability, that math learning disability, that even if they try to educate him, like I don't think he'll be able to process it.
Yeah.
So I think he's gonna need, that to be done, like supervised and done for him.
yeah,
Right.
That's not gonna be something that he can probably ever do on his own.
right. And
I meant like once it's calculated, like if he just, I mean, I don't know to what extent, but if he just knows this is what he's, what to look for or what to, have as far as his intake,
mhm,
so he had, I don't know, so that he has some kind of idea, but I don't know how.
I can remember going through like the disability one of the modules I did autism. So for like the ADHD, like specific ways that you can kind of improve their learning, like simple directions and stuff like that.
Yeah.
So if he is going to continue to be home alone, that's going to be a self-care deficit for sure. So I feel like they have to assess him for a period of time to know how much he really is able to do.
Yes.
And then like put in the interventions, like maybe they can print out pictures of, hey, this is your for dinner, like this is kind of what you have to do, kind of combinations of meals that he has at home and can eat.
Yeah, that's what I was thinking.
And if numbers are really tough for him, like let's maybe try and print out like a color, chart or something like that, and make it color coordinated or something that might be a little bit more visual, that he could reference, and I just hate to see this kid really managing his own diabetes alone,
Right.
in general. So I think that is a definite, family education topic that we really need to discuss with the family for sure, with his learning disabilities and all that. So is there anything else in that kind of little branch there that we need to talk about? I also wonder, is there a school nurse that is able to, like, if we could reach out to the school nurse maybe, or something, I don't know if that would be kind of overstepping, but, or have the parents reach out to the school nurse to have, Aiden be, go into with the school nurse or whatever to have his blood sugar checked.
Well, I think it would be a good thing because school nurse is already involved.
Was it?
Yeah, she's already involved. This is from her, this whole.
Yeah, so we're the school nurse.
Yeah.
But it does say that.
Yeah,
it does say though that he is able to provide a lot of self-care, and you have delegated some of his daily care to an unlicensed assistant personnel. So what are we delegating?
Right. Yeah.
And why?
And
So if you're the nurse, why are we delegating certain tasks, or how are we ensuring that it's fully being managed
True.
at school?
All right. So let's move on to we have 6 minutes left on this recording. Let's see here. History of present situation. You've only worked with Aiden 1 year previously in his glycemic control. had been fairly stable. Last September, you had checked in with his mom with the start of the year care planning. His A1C was 7.0. You recall at the end of the school year, it was a little less stable when his grandmother was placed on hospice, and Aiden missed a lot of school and had been reminded to report for medications before meals several times. You noticed since school started this year that his blood glucose has been elevated each morning despite having continuous glucose monitor CGM with alarms.
I think that just goes to show how vital his grandmother was in making sure that he was taking his medications properly and eating properly. 'Cause it looks as though it started to go downhill once that she got sick.
Yeah.
Stress also plays a role in kind of like blood sugar control. So he could be dealing with stress internally and not like verbalizing it. So addressing his coping strategies. Maybe he's, I know when I'm stressed, I want chocolate. So maybe he's just not eating right because he's stressed and
stress in
doesn't know
general
how to cope with it.
increases like the cortisol levels and all that, and that can affect blood sugar levels as well directly. So, you know, stress and diabetes don't go well together.
So we could, since she was on hospice, they can do bereavement services maybe, or grief support.
Good call. Let's see here. So, let's see the present situation. Anyone else want to read that?
Read it if you scroll down a little bit. Oh, sorry.
How's that?
All right, there you go. It is Monday morning, and you receive a call from your delegated caregiver that was supervising Aiden's breakfast insulin bolus, and Aiden's CGM is reading over 400 with a trend of increasing. He denies abdominal pain or nausea. You advise that his bolus is administered as you are just walking into the health room. You begin interacting with Aiden. You have him double check his blood glucose with a finger stick. His reading is almost 500. You have him check his ketones as per his school diabetic orders, which are trace. He continues to deny any symptoms other than a slight headache. You double check Aiden's insulin pump, and his pump and tubing is intact and patent, and his basal insulin is running. Upon further assessment, you find that Aiden has been estimating his carbohydrates for his dinner bolus every night based on about whatever my lunchtime carbs were, stating that he never really got the hang of counting carbs because his grandmother always did it for me. And they were always calculated at school. Aiden further states that his mom is working most evenings and sometimes he forgets about his dinner dose completely. He states he is unsure if he took any insulin last night. When you ask about his alarms on his CGM, he states that he silences them often because they are annoying. After speaking with Aiden for a bit, his blood glucose is trending downward and he is drinking clear liquids and continues to be asymptomatic. You have him go eat breakfast and tell him you would like him to come back to the office after breakfast so you can talk further. He agrees. When you call his mom, she states that things have been very stressful since her mom passed away and bereavement leave was only a few days, and states they do not have any additional family here. She also notes that Aiden and his grandma were really close, but he doesn't share his feelings. She states that Aiden is forgetful and that he doesn't like math, but should be able to calculate his own carbohydrates. She further said the doctor just talked to him about this. When you call his endocrinologist, she shares that Aiden's hemoglobin A1C was checked last month and was 12. She is concerned about the family and discusses further support.